Hi, everyone. Welcome to tonight's GFPD webinar. I am Katie Sacra, Director of Family and Community Engagement here at the GFPD. And along with Ryan Maple, our Executive Director, we will be moderating this evening's session. Tonight, we are continuing our two-part webinar series on navigating neurology and peroxisomal disorders. For those who may have missed part one of this series, that's absolutely okay. This session is designed to stand on its own. Both parts are packed with valuable information, and you don't need to have attended that first session for today's content to make sense. So that said, the recording from part one is available, and I'm going to share a little bit later about how to access that. For those of you who did join us for part one, welcome back. We're so glad to have all of you here with us, and we're especially grateful to our presenter, Dr. Isha Srivastava, who will be sharing this important information with our community and taking your questions tonight too. Dr. Srivastava is a dedicated physician scientist at Stanford University School of Medicine within the Department of Neurology. She completed her undergraduate studies at Johns Hopkins University, followed by her MD, PhD at Temple University, and residency in child neurology at Stanford. Her research is focused on exploring the nexus of lipid dysfunction, neuroinflammation, and peroxisomal disorders. She is developing innovative cellular models to investigate how lipid overload affects immune cell function and contributes to disease pathology. Her work aims to uncover therapeutic pathways that can be targeted to address lipid dysfunction and neuroinflammation in these disorders. Clinically, Dr. Srivastava specializes in pediatric leukodystrophies, particularly peroxisomal disorders, as well as pediatric acquired white matter injury. She is the Associate Director of the Leukodystrophy Clinic at the Stanford Children's Health, which has been designated a Center of Excellence by the Leukodystrophy Care Network. Through her clinical care and translational research, Dr. Srivastava is committed to advancing the understanding and treatment of pediatric leukodystrophies and peroxisomal disorders. We are also very grateful to have her serve on the Medical and Scientific Advisory Board for the Global Foundation for Peroxisomal Disorders. After her presentation, she will take some time to answer your questions tonight. You're encouraged to submit the questions at any point using the Q&A button or the chat feature. And Dr. Srivastava, thank you again for being here with us tonight, and I'm going to turn it over to you.
All right. And with that, we can jump right in. Katie, thank you so much for that lovely introduction. And as you mentioned, for those of you that were here during the prior seminar, welcome back. For those of you that were not here, I'm excited to talk to you about part two. I figured we would quickly review what we discussed in part one. So we're starting on a similar foundation. So, in part one, we talked about how neurological symptoms and peroxisomal disorders go beyond the brain and beyond seizures. That really the nervous system is dynamic over a person's lifetime. So, symptoms can look different and affect an individual differently as they grow and as they mature. So, they can change and evolve over time. I briefly discussed the role of an individual's neurologist. Obviously, I'm a little biased because I'm a child neurologist. And that role includes monitoring and management of these symptoms over time. However, neurologists are one of the multiple people on the care team, and so they can really help coordinate with other specialists within neurology, as well as those specialists from outside of neurology. And then the last big part from part one was that we really got into seizures and epilepsy and discussed the diagnosis, management, and seizure safety. And so, with that, I wanted to briefly talk about the outline for part two. Today, I will be overviewing the symptoms that are associated with mobility challenges, sleep disorders, neurogenic bowel and bladder, as well as leukodystrophy. And so for each of these symptoms here, I'll talk about how they may present in individuals with peroxisomal disorders, who might be on the care team, and discuss some management and treatment options. I have a list of resources at the end, and then there will be time, I hope, for question and answers, so I can clarify and answer any questions you have. One important consideration and reminder to keep in mind is that the goal of today's talk is to provide an overview. And so we're covering a lot today, but it'll be a general overview. So the treatment options that I'm listing are not exhaustive, but a glimpse of the different types of treatments available and the different treatment modalities. And then, as I'm sure many of you know already, not all treatment options are suitable for all individuals. And so this is a glimpse into the treatment landscape with the importance of talking with your care team so that your treatment can be individualized for you. And then my personal recommendation is as we're going, put in any questions you have as we go from one section to another. I don't want anyone to forget their questions, and so hopefully we're able to get to them. And with that, we will begin. So as I talked about previously, and as many of you may have experienced, there's a lot of neurological symptoms outlined here in gray that can affect different parts of the body associated with peroxisomal disorders. Today, we'll start with talking about different symptoms that can affect or cause changes in mobility. And so I've highlighted some of the symptoms in blue that can affect mobility in different ways. And the ones with the stars are the ones that we'll focus on a bit more. But first, I wanted to ask of the highlighted symptoms in blue, how many have you in the audience on this webinar heard of before, or how many sound familiar? And you can put a number in the chat, or you can put which specific symptoms you've heard of before. And so there should be a poll that is popping up, and if you can put it in, then I can get a sense of how many of these you're familiar with. All right. So it looks like many of you have heard of quite a few of these symptoms before. Um, and so some of this may be a bit of a refresher, some of it you may have heard. But what I wanted to start off with is hypotonia and spasticity. And so, hypotonia is a very prominent symptom in patients and individuals with peroxisomal disorders. Almost 94% of caregivers reported low tone, which is another name for hypotonia. Hypotonia can often be present from birth in individuals with peroxisomal disorders. And then it can cause changes and affect how an individual is able to move their head, how they're feeding, how they're breathing, how they're sitting, how they're standing, how they're walking. And this is during development, but it can affect these symptoms throughout a person's lifetime. I did want to remind myself to talk to you about the rubber band analogy, which is that if you think about a rubber band that hasn't been stretched, similar to the rubber bands you see here, this is similar to hypotonia, where the muscles are like the rubber bands that don't have enough tension to do what they need to do. And so they aren't able to hold the body up or move as efficiently. Now, with spasticity, this is actually the opposite problem. So the muscles, if we think about a rubber band, is snapped or held too overstretched. And so the muscles are too tight, and that can cause stiffness and pain and difficulty moving freely. Spasticity can also be called increased muscle tone or increased muscle stiffness. This can actually develop over time. So sometimes individuals can have both spasticity and hypotonia. Um, or sometimes hypotonia over time can result in spasticity. And the last part of this, of these symptoms that I wanted to emphasize is contractures. So if we think about a joint, here is a picture of a person's elbow and how the elbow can move in these directions shown by the arrows. Contractures occur when this muscle in your arm, your bicep, becomes too tight. So then the individual is not able to move their elbow in all the directions it's supposed to move. The range of motion of the elbow is limited. And so this is really what we want to prevent because it can affect how you're able to move and how far you're able to move your joints. Next, I wanted to highlight that movement disorders can also affect mobility. So, the first movement disorder that I wanted to talk about, or movement disorder symptom, is ataxia. And so, ataxia is also thought of as trouble with balance and coordination. Here is a schematic or a drawing that shows a young lady that's having trouble walking because of ataxia. Sometimes people will describe it as walking like they're on a boat, but they're on land. Ataxia can also affect the arms and legs specifically, so it can be really challenging reaching for objects or drawing or writing. And balance problems, such as is illustrated here in this lady, are reported to affect up to 63 people that are living with Zellweger spectrum disorder. So it is not an uncommon complaint. Next, I wanted to talk briefly about dystonia. I know this isn't as common in peroxisomal disorders, but I wanted all of you to hear and know what it is so we can monitor for it. Dystonia is intermittent, involuntary muscle contractions, and it can result in twisting or abnormal postures. Here's an image of a gentleman that is having dystonic postures, and you can see that his torso is in a twisted and uncomfortable looking position. Dystonia can be quite painful if it's ongoing for long periods of time. And lastly, I wanted to mention that tremors, which are also thought of as rhythmic involuntary shaking, this is very different from seizures and the type of shaking that's happening. It can affect the arms, the head, the legs, and this can make it really difficult to walk or to reach for objects. And it's reported in about 35% of individuals with peroxisomal disorders. So it is occurring in peroxisomal disorders. And all of these symptoms can happen concurrently in an individual. Some of these symptoms can come and be at times more prominent. And like I mentioned, over time, these symptoms may change in how they're affecting an individual. So, what are some things that can be done to help manage how these symptoms are affecting mobility? Well, first, I wanted to mention that sometimes the goal of management is not to eliminate the symptom completely. That can be really challenging in someone that is medically complex, like children and individuals with peroxisomal disorders. Instead, I often think about it as the goal of mobility management is how I can help facilitate activities that are important for the individual. This can be activities of daily life. Can we make dressing easier, bathing easier, diaper changes less traumatic and easier? If the individual is able to move, how can we facilitate and optimize what they're able to do? How can we help engage and enhance school participation and for individuals to enjoy and participate in their environment? And most importantly, how do we minimize pain and discomfort? And so those are often the goals of mobility management. One thing I wanted to emphasize is that early and consistent therapy is really important for preventing contractures. Contractures are often symptoms that will develop over time. And then I think I've emphasized this already, but from the voice of patient report, which sometimes you'll see in the presentation as VOP, treatment needs for mobility increased over time. And so, as I mentioned in the first part and throughout the talk so far, neurology symptoms, like the symptoms I've mentioned, can change over time, as can mobility needs. As the body is doing more, or trying to do more, it may need more help. In terms of your care team for mobility management, it could include a general neurologist or even a movement specialist if there is very severe or prominent tremors or ataxia or dystonia. It can include a PM&R physician that can help coordinate some of the therapies and treatment options that we'll see on the next slide. Therapists are the cornerstone of mobility management. They're really, really important in helping figure out what are additional exercises so that we can help achieve these goals. And then there are surgical options and surgeons that might be helpful as well. Not all of these individuals will be on the care team from the get-go, but they may be added and changing over time. With mobility management, as I mentioned, your therapists are going to be your cornerstone. They're often so important in figuring out and helping strategize how to preserve that range of motion. What strengthening exercises are really important? What are safe positioning tools that can help facilitate all of those activities that we talked about? They can also, especially physical therapists, can help with orthotics, and this can help maintain healthy, more comfortable positioning of your arms and your legs, and sometimes even your torso. The therapists, in collaboration with your physicians and other medical providers, can also help brainstorm assistive and adaptive devices. Some of these, I think, we all may be more familiar with, such as wheelchairs and walkers. But I also wanted to highlight adaptive equipment and this diagram here, which shows other adaptive devices, such as bathroom safety in the toilet, communication devices, adaptive clothing, as well as eating utensils that can all be helpful in trying to create some degree of independence for affected individuals. Next, I want to shift gears a bit and focus on mobility management, specifically with spasticity. I've listed here, there's quite a few different oral medications. Some of these can also be used for dystonia that can be really beneficial. And often are the starting points of spasticity management. I made a little asterisk here next to black baclofen to remind myself to really emphasize that this is one medication that should never be stopped abruptly or discontinued without letting your provider know, because it can cause a lot of negative symptoms if stopped abruptly. So, oral medications are the first tier, but other options can include Botox or botulinum toxin or phenol injections. And these are to target specific muscle groups and help relax them. There is also the option of surgically implanting a baclofen pump that can release baclofen throughout the day and continuously. And then, as I mentioned, there are options for surgical interventions, and these interventions can target the sensory nerves that are causing the muscles to continue to contract, causing spasticity. It can help, or surgery can target the muscles or tendons. As I mentioned, sometimes the muscles themselves can become stiff or tight or short. And then lastly, spasticity management can also target the bones. So when the muscles and tendons or the nerve surgery may not be a suitable option, there is a surgery that can help target the bones themselves. As I've mentioned, not all of these options work for all individuals because the pattern and severity of symptoms can vary from individual to individual. And so, which of these and which combination of these is ideal for you or your family member will need to be discussed with your medical team. All right, we will move over to the next symptom. So, we'll talk about sleep disturbances. And so, sleep disturbances are also quite often seen with individuals with peroxisomal disorders. And I wanted to ask you in the chat, Has sleep been a challenge for you? Or has sleep been a challenge in your family? And there should be a box that pops up. Please feel free to send me what your thoughts are. Yeah, it looks like it's a bit split from those that responded to the question. So some of you have sleep has been a challenge and some not. So we'll talk about what type of sleep disturbances can occur in patients, in individuals with paroxysmal disorders. So there can actually be quite a different types of sleep problems in individuals with paroxysmal disorders. And so here is a schematic or a little picture of a little child that is not happy to see their alarm clock because sometimes the problem, the sleep disturbance is actually difficulty waking up or feeling really sleepy during the day. This other this other image here shows a child that looks like it's late at night. They're having difficulty falling asleep. So the different types of sleep disturbances are shown here. It can be difficulty falling asleep, difficulty staying asleep, waking up several times within the night and then having difficulty falling asleep, irregular sleep-wake cycles, which can be very disruptive to the individual as well as the family, excessive daytime sleepiness, or having sleep disordered breathing. And the one I put as an example is obstructive sleep apnea. You may have all heard that term before. Sleep disturbances can sometimes be the primary problem, but they can also occur secondary to something else, such as medication side effects. Many of the medications we just talked about for spasticity management can cause excessive sleepiness or sedation. Sleep can also be disrupted because of pain or comfort, or if there's something that is interrupting sleep, such as receiving GI feeds, respiratory support, reflux, or needing to be repositioned. What I want you to remember is that if there's a concern about your sleep or your family member's sleep, is to bring it up with your neurologist. There's a lot that can be done for sleep management, and our goal is really to make sure that the individual and hopefully the family is getting the most consolidated and restorative sleep possible. And so it's both the quantity of sleep, but also the quality of sleep. And those of you that participated in the Voice of the Patient report, this was an important clinical outcome. In terms of your sleep management team, it can include your general neurologist. It can also include a pulmonologist or a lung doctor, as well as a sleep specialist. And some of the treatment options can also include a surgery team or your ear, nose, and throat surgeon or doctor. And what I want to emphasize is that sometimes the first step can be getting an additional diagnostic test called a sleep study to help categorize and quantify the type of sleep disturbance you're having. Sleep management, the first and lowest lying hanging fruit is promoting good sleep hygiene. And so there's a lot of different factors that can aid in getting good sleep hygiene. But some of the ones I wanted to highlight include a consistent sleep schedule. This can help your body get into a routine of when to wake up and when to fall asleep, as well as a relaxing bedtime routine. And this can help signal to the body that it's time to fall asleep. Making sure that the room and the environment that one is sleeping in is comfortable. And so I like the imagery of creating a sleep sanctuary that's quiet, dark, comfortable. Limiting screens and devices as you're able to in the bedroom can minimize disruptions. And then avoiding a large feed or a large meal close to bedtime. Again, helping getting your body ready to go to sleep. The next step will be to treat the underlying causes. As I mentioned, sleep can sometimes be secondary to something else or another concern. This can include treating and diagnosing and treating sleep disordered breathing or obstructive sleep apnea. And the treatment for that can include positioning, a CPAP machine, or additional respiratory support, and also surgical intervention that can help open up the airway. It can also include, if there's pain concerns overnight, optimizing pain management or neuroirritability. It can also include optimizing respiratory needs and GI needs so that they are minimally affecting sleep overnight as able. And then the last part I wanted to emphasize is that when the body is stressed, worried, anxious, it can affect the quality of sleep as well. I want to talk briefly about the medication options for sleep. And one that I typically recommend to many of my patients is melatonin. It's generally very well tolerated and helps with sleep onset. So, those that are having trouble getting to sleep, though rarely some of the side effects can include these vivid dreams, and sometimes it can make you groggy in the morning. Now, for the rest of the medications that I'll list momentarily, I wanted to highlight that at least for children, there is no FDA approved medication for sleep management. And so there's quite a bit of variation in what medications are used and what is used first. But I wanted to list some of the medications so that you've become familiar with some of the names and treatment options. The other medications can include clonidine, and I put an asterisk to remind myself that to mention this is another medication you do not want to discontinue or stop abruptly, as well as trazodone. Both of these, clonidine can help with sleep onset, and trazodone can often help with sleep maintenance. And then gabapentin is not a medication that directly affects sleep, but one of the side effects of gabapentin is sedation. And so sometimes you're using the sedation side effect to help with sleep, as well as addressing any sort of pain or irritability. So you're getting two symptom management in one medication. And then I wanted to at least emphasize that typically over the counter antihistamines or over the counter sleep medications are often not recommended for long term sleep management. And that's because often they can cause paradoxical agitation. So rather than helping children and adults fall asleep, they can make you more activated, and also your body can build up a resistance to some of these medications over time, so they're not great for long-term sleep management. And with that, we will switch gears over to neurogenic bowel and neurogenic bladder. And these are, from the Voice of the Patient report, some of the most frequently reported patients among individuals and caregivers of, of paroxysmal disorder individuals, and can affect the daily life quite a bit. And so important to hopefully understand what are the symptoms to monitor for, and what can we do about them. So, why does neurogenic bowel and bladder occur in paroxysmal disorders? And so I wanted to put this diagram here. It's quite tiny, but what I wanted to highlight is you have your brain, you have your spinal cord, and then from the spinal cord, you have nerves that go to your gut, here and to your bladder. And so there are signals that are coming from your brain all the way down to your bladder, as well as from your brain all the way down to your gut. And these signals are helping the body control bowel and bladder movements, when to pee, make sure you're peeing enough, when to poop, make sure you're pooping all the way. And so when these signals aren't being sent or aren't being received properly, the body can have trouble managing bowel and bladder symptoms. And so this is what's being disrupted in peroxisomal disorders. This, as you can imagine, can cause a few different types of bowel and bladder symptoms. And so I've listed the names here, but I want to take a moment to go over what these may actually present as. So for overactive bladder, this can present as an urgency having to go to the bathroom and having to go to the bathroom more frequently. This can be it can present as having difficulty controlling when to go to the bathroom, leading to wet clothes and wet diapers or accidents. Underactive bladder is in some respects, the opposite problem. Instead of having to go to the bathroom all the time, your bladder is actually not able to completely empty. And so you may have, for example, small amounts of urine coming out or still feeling full, even after you've peed. Um, and then this type of neurogenic bladder is actually associated with increased risk of recurrent urinary tract infection. So sometimes that can be the main symptom as well. And then for neurogenic bowel, it can present as constipation of varying severity, as well as, again, that incomplete emptying feeling like you have to poop, but not being able to, or having accidents or soiling accidents as well. That can be a symptom of neurogenic bowel. And as you can imagine, and many of you may have experienced, these symptoms can really affect the quality of life of an individual if they're feeling like they always have to go to the bathroom, or when they go to the bathroom, they're not able to feel any relief. With accidents, either bowel accidents or bladder accidents, it can really affect the skin in your GU area. And then it can affect school or work participation and can also affect a sense of independence. But what I wanted to really emphasize here is this last point, that's oftentimes your medical team doesn't see the daily impact on the day-to-day life. And so sometimes these symptoms can be invisible unless the individual or families bring it to our attention. So if any of these symptoms that we talked about are occurring, it's really important to tell your medical team. With that, we'll go to neurogenic bowel management first. I wanted to list out some of the important team members for this management. Your neurologist can help, but really it's important to loop in the gastroenterologist or your GI doctor, your nutritionist, as well as your physical and occupational therapists as well. And again, the goal is really to help as much of this function as we can with some of the first tier interventions, which is diet modification, increasing fiber, increasing hydration, and bowel training, so scheduled voiding. The next step, and these don't have to be sequential, sometimes many of these are happening together, is helping the quality of the poop. So stool softeners like polyethylene glycol, which is Miralax, decosate sodium, as well as stimulant laxatives if the gut is a little less active or sleepy. The stimulant laxatives can wake it up. Sometimes rectal suppositories or enemas can also be helpful to, again, stimulate that gut. And then lastly, there are surgical interventions that can happen as well. Moving on to neurogenic bladder management, here the goal, similar to neurogenic bowel management, is reducing accidents, and for bladder management, preventing urinary tract infections, protecting the skin, as I mentioned, with accidents. The skin barrier can be affected, and how to make daily routines more manageable. The neurogenic bladder management team really centers around a urologist. Sometimes there are neurology subspecialists. As I mentioned, neurologists can have subspecialties within neurology, and there can be a neurourologist. The PM&R physician and your physical and occupational therapist can be really helpful as well. And here, there may be some additional diagnostic testing, specifically to help identify the type of neurogenic bladder you're having. And so that might be needed first before the management begins. The management of neurogenic bladder can include, again, similar to neurogenic bowel, voiding scheduled or timed voids, as well as preventative antibiotics if there's been recurrent urinary tract infections. And then medication management depends on the type of symptoms and the type of neurogenic bladder you have. If there is that overactive bladder, then medications that help relax the bladder muscles can be helpful. If you have the hypoactive, underactive bladder, then sometimes helping the bladder empty and contract can be helpful. There's also the intermittent catheterization to help empty that bladder if the body's not able to do it fully by itself. There's also Botox that can go directly to the bladder muscle if it's too active, as well as implantable devices that can slow or stimulate the bladder. And lastly, surgical options as well um, are available. Again, not all options are appropriate for all individuals. And so the goal again is reducing accidents, usually preventing UTIs, protecting the skin, and making routines more manageable. And so which combination of these treatment modalities work best for you will be individualized and different for each person. And with that, we will go on to our next and last symptom or topic for today, which is progressive leukodystrophy. And so with this, in the Voice of the Patient report, leukodystrophy was ranked as the second most frequently ranked symptom that can impact daily activities. And so that is encompassing how much this can affect an individual as well as a family. And so with that, what is leukodystrophy? I wanted to break it down. Leuko means white, dystrophy can mean breakdown. And so this is really a breakdown of the white matter. And so in the brain, you have gray matter and white matter. White matter is really the myelin. And so leukodystrophy is a breakdown of the myelin. The myelin in this little neuron or nerve cell that resides in the brain, it's this red part here. And so the myelin is this insulation that is around the neurons in the brain and the spinal cord, and it can help transmit the signals that need to go from the brain to the muscles through the spinal cord more efficiently. And so when it's being broken down, those signals are not able to be sent as efficiently or always get to where they need to go. Leukodystrophy can present as a couple of different symptoms. So it can present as a regression or a loss of previously acquired skill. This can be a loss of being of an individual that was walking independently, now having more and more trouble walking. It can present as an individual that was able to talk and interact with the environment, having a change in that ability. It can also affect or present as worsening mobility and coordination. And sometimes this can be tricky because we've talked about how mobility and coordination and neurological symptoms can change over time. And so this can often overlap with some of that natural progression. It can also present as sometimes more rapid or more noticeable cognitive changes or learning difficulties. Again, a change or a step back in both of these areas can present as vision or hearing changes or loss, um, or an unexpected or unanticipated worsening in both of these areas. And then lastly, it can present as a sort of abrupt change in mood or behavior. Obviously, with leukodystrophy, it doesn't always present the same way in all individuals. And as we've heard from families, such as all of you, in the Voice of the Patient report, the progression, how fast these symptoms that we talked about are changing with a leukodystrophy can be pretty heterogeneous. Some families described it as gradual, some described it as rapid or sudden. So it seems that there's quite a bit of differences in how this presents and how fast things change. Um, it is not occurring in all individuals, but was reported in up to 23 of individuals with paroxysmal disorders. Unfortunately, at this time, there's no specific treatment to stop or correct the leukodystrophy at this time. And so a lot of the management of leukodystrophy is trying to manage the symptoms that are occurring. Physical therapy, occupational therapy, speech and language therapy to help preserve that function, preventing secondary complications, managing those symptoms that we already talked about, spasticity, sleep, bladder, and monitoring these changes so that we're able to adapt some of these other treatment options. And then incorporating a palliative care provider as a partner in how to optimize living well and optimize quality of life. And the goal for leukodystrophy management is to help, as I mentioned, preserve the function, maintain comfort, optimize the quality of life and participation at every stage of the leukodystrophy. And with that, I know we're coming close to time. I wanted to review some of the takeaways from this part of the talk. And so I hope what I've shown you is that the neurology team or your neurology provider can collaborate with other medical providers to help manage the symptoms that we discussed today, which include mobility, sleep disturbances, and neurogenic bowel and bladder. That often the goal of symptom management is not to eliminate the symptoms, but how to optimize activities of daily life, enhance school participation, enhance engagement with the environment, minimizing pain and discomfort. And I don't have it here, but reducing complications. And honestly, this is an area that can be really helpful to get feedback from individuals or families. What is your goal with managing these symptoms and voicing that? And with that, I wanted to highlight that affected individuals and their family members are the experts in your family. And so what you're observing at home, what your family is observing at home, and what the caregivers are observing at home really can help guide the medical decisions and help us providers find the best treatment or combination of treatment options for you. Treatment is always individualized because no symptoms, no individuals are the same. And if you're ever wondering, why isn't this being considered? Why isn't this medication or this surgery being considered? It's important to ask. Um, and then I think I wanted to, in light of our discussion about leukodystrophies and progressive symptoms, really emphasize that if there are new neurological symptoms, it's important to tell your neurologist, and not waiting until the next visit. And so, with that, I have put together some of these resources. I wanted to just briefly comment on a couple of things. One, the Child Neurology Foundation, or CNF, has lots of disorder directories and symptom directories. So they have specific pages for hypotonia, spasticity, and ataxia that can be helpful. And it's all very family friendly about causes, treatment, and therapy options, similarly with healthy children. I wanted to emphasize that this link here is for the American Academy for Cerebral Palsy and Developmental Medicine. And though the underlying conditions are different, so cerebral palsy is different than peroxisomal disorders, the care pathways that they outline here and the symptom management strategies that they outline for hypotonia, spasticity, and dystonia, some of those strategies and family support are directly applicable to individuals with peroxisomal disorders. And then these are really great family-friendly sleep websites that can help explain some of the different types of sleep disorders I mentioned. And lastly, I didn't put this here last time, but the actual citation for the Voice of the Patient report. And I believe Katie will be sending you these resources with the appropriate link for the symptom prevalence study as well as the Voice of the Patient report. So you should have that to look at. And with that, I am happy to take questions.
Thank you so much again for a fantastic presentation. Really appreciate it. And yes, I just put in the chat that I have all the links ready to send to all of our attendees after we finish up this evening. Just wanted to thank you again, though, because this is such important topics that are impacting so many of our families. And like you said, we're going to move into that Q&A portion now. As a reminder, I know I've seen a few already come through, but just a reminder to those that have any questions, you can pop them into the Q&A button beneath the player window. And you can also put them into the chat box, and they can come actually right through to Ryan, Dr. Srivastava, and myself. And one of the questions that we had received when we were talking about sleep was in regards to sleep. Can you discuss a bit more about how a progressing leukodystrophy can affect sleep or cause neuroirritability in sleep?
Yeah, so um, I think as we talked about in terms of symptoms that can affect or symptoms that a leukodystrophy can present with, the leukodystrophy that's progressing is affecting that white matter. And so it can affect a lot of the sleep centers as well as the other centers in the brain and and how the different parts of the brain are talking to each other. And so sometimes that the loss of those signals or the disruption in those signals can cause changes and changes in sleep and an increase in irritability or aggressive behavior or a sudden change in the behavior that doesn't have any other cause and seems like it's coming out of nowhere. For sleep, it can also cause any of the different types of sleep symptoms that we talked about. But a couple that come to mind that I'll highlight is difficulty with falling asleep, as well as multiple nighttime awakening and having just a disordered sleep schedule. So, a schedule that is not following sort of the nighttime, daytime routines.
Thanks so much for taking the time to answer that for our families. The last time that you talked about EEGs as a tool, that neurologists use when evaluating for seizures. A lot of our families, it can be a little bit confusing because we see, all these electrodes that are put on the head. Can you share a little bit about the difference between the EEG that's ordered for seizure activity versus when it's done for a sleep study and what providers are really looking for when they're doing these at different times?
Yeah. So you're absolutely right that part of the sleep study, they'll put the electrodes or the stickers on your head or an individual's head. And you may or may not appreciate that there's fewer electrodes. And so the EEG, when it is done for seizure rule out or seizure evaluation, there's a lot more electrodes that are put on. And there's a lot of different or additional brain waves or areas of the brain that are being monitored because the seizures that are being looked at can occur in different parts of the brain. During the EEG, most of the time for seizures, we try to capture awake and asleep. And so that EEG that's done for seizures is able to capture sleep. But it's usually done for much shorter times because we just want to see the brain activity in the background when the brain is at its baseline and see if we're able to capture seizures. Now, for the EEG that's part of the sleep study, instead of, let's say, having 24 stickers on your head, you may only get 12. So it's a limited EEG that is being done. It's not able to capture all the different areas like the full EEG for seizures. It is just capturing the areas that are important in the sleep transition. So as the body is transitioning from the different stages of sleep, that is what the EEG in the sleep study is looking for so that they can see, okay, how are you breathing when you're in this stage of sleep? How long are you in this stage of sleep? They're not evaluating seizures because there aren't those EEGs during the sleep study are not getting the full picture. I know that was a very long explanation, but I hope a detailed one and one that made sense for all of you.
I think it was a great explanation. I appreciate you taking the time. I know that so many of our families, including my own, have had EEGs for different reasons, and that understanding is really empowering for us to better understand what's being done and why these tests are being ordered. We do have a question about. I'm wondering if the presentation of leukodystrophy is really that low in PBD, or if families or those affected just have not had MRIs to confirm the leukodystrophy.
Yeah, you're that could definitely be the case. I would say the MRI for leukodystrophy is always helpful because we can see a change, but sometimes the clinical symptoms and clinical changes that families are reporting to us, and especially when they're happening suddenly um, can also increase the suspicion for leukodystrophy. But I anticipate that as there's more awareness that this can happen and there is more monitoring to see if these symptoms are changing or to look at an MRI or to take a image of the brain, you're absolutely right. We may see that it's in fact more common than what we have, but this is the number I think that we have right now.
Yeah, and I actually wanted to share with everyone that the resource that you actually are providing that I'll make sure is linked in a follow-up to everyone this evening. That publication on the symptom prevalence, that question was actually part of that publication of not only the abnormal MRIs, but then also how many people that were answering the survey for that publication actually had MRIs done. So if you want to, if whoever asked that wants to take a look at that article that Dr. Srivastava linked in resources, it's actually going to be able to share that information with you, so you can actually see that that percentage of people that were able to say we didn't have an MRI, which I think leads to a great follow-up question of if you have someone who's unable to obtain a brain MRI, whether that's an older individual with a cochlear implant that's not MRI compatible, or someone who's too high risk for sedation, or just, they can't hold still long enough for that study. Is there still value in obtaining a CAT scan to look for changes? And if a CT is limited in that regard, how do you typically approach diagnosing a leukodystrophy in those situations? Do you, rely on clinical presentation, the changes happening?
Yeah, I think that um, that a CT can be helpful. We briefly talked about the difference between CTs and MRIs, and I would say MRIs, when they can be done, provide a lot more detail, especially about the white matter in the brain. But the CTs can pick up some of those changes as well. It might not give as detailed of a picture, but usually when the leukodystrophies are present, they're not subtle on imaging. So I would say if the individual can get a CT, it can be helpful to provide some information about what are some of the changes that are occurring in the brain, especially if they've gotten neuroimaging before. When no imaging can be done for whatever reason, then yeah, oftentimes we are basing the diagnosis of a, let's say, suspected leukodystrophy based on the clinical changes that the family or the individual is telling us about.
Thank you so much. And there is, I did see that somebody had raised their hand, and I just want to remind everyone that you can submit your questions through the Q&A. There's a Q&A button below the player and then window, and then there's just below actually where you see that screen that says questions and Dr. Srivastava's picture. You should see an area that just says Q&A. And then there's also the chat function. You can type your questions in there as well. And then I do have another question that's in here. I'm not fully sure if the person who asked about they put in here about cycle vomiting. I'm wondering if they're talking about cyclic vomiting, the syndrome possibly. I don't know fully what the question might be. If you want to share a little bit more or even reach out separately afterwards, we're happy to try to get an answer to you. Dr. Srivastava, if you want to address that quickly, it's kind of asking if you're familiar with that. Um, but I'm not sure
Yeah,
how it's related to the peroxisomal disorder or not, but I'll let you go ahead and tackle that one.
yeah, I would say I'm familiar with cyclic vomiting syndrome, which sometimes can be a migraine variant. But I would say oftentimes with any individual that's having vomiting, whether it's cyclical or intermittent, one of the things to consider is just ruling out other GI or gastrointestinal issues and potential contributors. And so to look at what are all the different parts of the body that could be causing this, whether it's neurological or another part of the body, like the gut, that might be causing it, and how those are interacting. But I'm happy to try to answer that maybe a little bit more specifically or precisely once we have a little bit more information about the concern or the question.
Thank you. And I'm going to just give a minute to see if anyone else had any other questions they wanted to submit to us. I know we covered a lot of important topics that impact our families so much. I appreciate you taking the time to share with us. I'm just going to give it another minute because I know that sometimes those answers, even to those questions, make people just come up with more questions. And then just a reminder that you can always reach out to us at the GFPD too. If a question hits you later on, we're happy to assist you if you want to reach out that way too. And one last question that we have. I know we're running a little bit late, but it was such an important topic. I don't want to rush us. So if somebody, actually, I think we see this a lot in our community where we see the kind of the feet turning in or maybe posture changing over time. Um, it's kind of hard, I think, for all of us parents, even to myself included, wonder what's driving that. Is it accurate to say that it can start with abnormal brain signals when you start seeing like the feet turning in and those posture changes? I know you even showed some pictures earlier. Are those signals causing those ongoing muscle contractions over time? Is that what's leading to the changes in that joint alignment and even skeletal differences? And can anything be done to slow down or stop that progression?
Yeah, so um, I would say there are the changes or disruptions in the signal, whether it's coming from the brain to the spinal cord to the nerves to the muscle. And so changes or interruptions along anywhere on that axis can lead to the muscle spasticity, to the muscle sort of contracting or doing something that it shouldn't, or at an inappropriate time. But you're absolutely right, Katie, in that sometimes there can be an injury or um, uh, a specific part of the brain that can be more affected. And so oftentimes when there is when the cerebellum or the back of the brain is affected, we can see more of those trouble with movement, trouble with walking, that ataxia, sometimes those tremors that we talked about. But interruption along any of that pathway can lead to some of the spasticity, dystonia that I mentioned before.
Thank you so much. I just wanted to make sure that got asked because I know we see that so much, and I know there's always questions at any time I'm talking with families or overhearing conversations. So I appreciate you taking the time to share. And just as we wrap up today, if you want to go ahead and advance to that next slide, I want to share just a few more things. I know we're a little over, but you know, I I really appreciate you being here with us and sharing with our community. We had part one, which was really just amazing. And it's, like I told everyone at the earlier when we first started, they really stand alone on their own. They're both powerful webinars that you've been able to present to our community. I want to make sure that everyone here knows if you did miss it or you want to go back to it and just, check on a few different things that maybe you want to recollect and share with someone else. It is available now on our GFPD YouTube channel. So it's going to be the most recently posted video. And when I send out an email afterwards tonight, I'm going to make sure that I send that link to everyone as well. And if you want to go ahead and go to the next slide, just a quick reminder, again, talking about these topics like neurology and mobility issues, the GFPD patient registry for paroxysmal disorders often gets mentioned, especially given that is how we strengthen our patient voices. That's how we provide critical data for researchers to use to be able to, advance drug development and treatment options to help improve paroxysmal disorder care. When we were talking, Dr. Srivastava was sharing all these great ways that we can manage these symptoms, and there are symptomatic treatments for all these different things, but finding out what's working and things like that, that's where we collect even more data and can improve that care. So the QR code on the screen can take you to a web page with more information, including contact details and steps on how to get involved. And then one more, I think, was the last slide.
Yep.
So just again, thank you again so much. I'm just so grateful for you being here, for helping us better understand this important topic. Um, Neurology just impacts so many areas of the body, and it really, honestly, it impacts every aspect of daily life for so many of us. And we're grateful for you being here, providing clarity and insight with our entire community. To our audience, thank you for being here and engaging with us tonight. We want to give a special thank you to Miriam for supporting this webinar and helping us continue educating and empowering our community of families and professionals who care for our GFPD warriors. To stay up to date with the GFPD and learn about events just like this tonight, make sure you're receiving the GFPD Top 3 email. The QR code on the screen can take you to a page where you can easily sign up for our biweekly updates. And then just again, thank you everyone. Such great engagement tonight. I hope everyone has a wonderful rest of your day or evening, wherever you're joining us from. Thank you so much.